Good morning, everybody. Happy New Year's. Happy Tuesday morning. Welcome to Grand Rounds. I'm going to have Dr. Williamson come up here and introduce our speaker, Dr. Melissa Parks, in just a minute. But as it's the first Grand Rounds of the year, I just wanted to say a couple minutes of words on Grand Rounds in general and our plan and schedule for this year. We have really the first half of the year mostly scheduled, and I'm very excited. I think there's going to be a lot of great presentations and great speakers, both here from PCH and from all around the country. So I'm excited and hope that it's helpful and meaningful for you guys. We are always interested in your input in Grand Rounds and on the topics and speakers. So please don't hesitate to let me know, let Antoinette know if you have ideas you'd like to see or speakers here at PCH or anywhere that you'd like to see here at Grand Rounds. We also have a CME committee that meets once every 2 months over lunch. And that's a fun and active committee. And if you're interested in joining us, we'd love to have your input and let us know, and we'll get you an invite. One thing that's going to be different in 2019, we're going to attempt again to provide MOC Part 2 for Grand Rounds attendance. This unfortunately does not apply to trainees. MOC Part 4 does apply for you guys. You guys can bank MOC Part 4 credit for later use, but Part 2 you cannot bank. But it does apply to attendings, and we're going to try to offer, or the goal is to offer 10 points. And what you do is if you get at least 10 questions right, basically each lecture will have a question associated with it. You can access the question as you walk in with the QR reader in the back or through the electronic link through the email. That will send you to SurveyMonkey. It'll be one question, and a rationale for the right answer will be provided. And if you attend at least 10 lectures and answer 10 questions right over the year, then you get 10 MOC Part 2 points. And it's just 10, so it's kind of all or nothing. If you get 9 questions right, that's 0 points, and if you get 11 questions right, that's 10 points again. We have to designate one number for the ABP, but we think that 10 points is a meaningful number for the attendings, and hopefully that is a helpful and useful thing for you guys. So please give us feedback on that as well, how that's going, but I think that's going to be a fairly seamless thing to do and hopefully a good addition for Grand Rounds. So without further ado, let me have Dr. Williamson come up. Thank you.
Good morning. I am happy to introduce our current fellow in Pediatric and Adolescent Gynecology this morning. And just a little background, so she went to medical school at Ohio University and then completed her residency in obstetrics and gynecology at Eastern Virginia Medical School. And so she's been with us about 6 months. She'll be here another 18 months. And she's also working on her MPH at this time. So if you have questions and anything, please definitely get in touch with Melissa. So Melissa Parks.
Thank you. And it's an honor to be the first Grand Rounds presenter today. I didn't realize that, so that's fantastic. So today's presentation is going to be on heavy menstrual bleeding in the adolescent patient. And I think, as some of you may know, this is a clinically difficult, challenging thing to manage in the adolescent population. And so really the purpose of today is to review the clinical presentation and management of heavy menstrual bleeding, specifically in the adolescent population. So this is just a little overview of what we're going to discuss today. I just want to highlight that I wanted to start off with what a normal cycle is first, and what's normal I think helps you to better understand why abnormal things are happening. And then we'll conclude today's discussion with a case presentation. So menstrual cycles have been regarded as a surrogate indicator of overall menstrual health, adolescent health. But unfortunately, a lot of patients and their families, they don't really know what's normal, and this can be further compounded by providers who may have knowledge gaps in that as well. So number one, what is a normal menstrual cycle interval? For an adolescent patient, this is 21 to 45 days. In an adult, though, it's 21 to 35 days. Typically, you're going to bleed for less than 7 days, and then your normal blood loss is about 30 to 40 milliliters which is equivalent to about 3 to 6 pads or tampons that are saturated per day. So the national examination, the national survey and examination here down at the bottom, they had a study back in 2011, and they were looking at the mean age of menarche in adolescent females, and it was 12.43. But what I wanted to point out here is that it differs across racial and ethnic groups. So depending on the model, in non-Hispanic whites it's about 12.7, in black females it's about 12.1 or 12.3, and then in Mexican Americans it's about 12.2 and 12.5. So this just again helps you to understand what is normal and what when you're having a patient that's coming in, what are their presenting symptoms, and does that make sense? So we're going to bring you back all the way to med school. I'm sure this gives people nightmares, but this is the menstrual cycle. We're just going to kind of break it down for you. So it's broken down into 3 phases. So you have your follicular phase, ovulation, and your luteal phase. And if you look at the endometrium here, this is also further broken down into the proliferative, the secretory, and then your menstrual phase here. So your hypothalamus, it's going to release your GnRH, and it's going to stimulate your anterior pituitary. Okay, so we're going to look right here. So in green here is your FSH, and blue is your LH. So at the beginning of your follicular phase, this is when menstruation is occurring. So this is the very first day that bleeding starts. That's the start of your menstrual cycle. During this time, you have an increase in your FSH and your LH. The LH is going to stimulate the theca cells in the ovaries, and they're going to produce androgens like androstenedione and testosterone. You have a little bit of estradiol, but it's mostly the androgens. The FSH is then going to stimulate the granulosa cells in the ovary, and it's going to further upregulate FSH receptors. It's going to help to recruit follicles, and then it's also going to allow the granulosa cells to aromatize the androgens that the theca cells are producing, and then that's how you get estradiol. So as you see, with your FSH starts to increase in this follicular phase, your estradiol is also increasing. The estradiol here is going to work on the endometrium, and it's going to stimulate proliferation of the endometrial stroma. During all of this, you have a dominant follicle that is selected and is continuing to grow and mature. So roughly about 14 days into the cycle, it depends because this follicular phase can vary between cycles. You have this positive feedback that develops, and I'm not really sure why this happens, but you have a positive feedback of this estradiol and this progesterone here that's being produced that leads to an LH and FSH surge. And this is what actually is going to trigger ovulation right here. So ovulation is when you are releasing the oocyte, and that will be then directed into the fallopian tube. That the dominant follicle then after ovulation will then involute and become a corpus luteum, and then at that point it's the main source for your estrogen and progesterone. But during this, you're now into the luteal phase, but during this luteal phase you're going to have a predominance of progesterone that's being produced. And this is going to work on the endometrium and cause spiralizing of the arteries. You'll have increase in secretory glands, and it's basically maturing the endometrium and preparing itself for implantation. If about 8 to 9 days or so after the ovulation, if there's no fertilization, then at that point that corpus luteum is going to involute into a corpus albicans, and you have cessation of the progesterone and estrogen that it was producing. During this time, as you can see, the FSH and LH were pretty low, and that's because these progesterone and estrogen were exerting a negative feedback. So as these decrease, then that negative feedback is removed, and FSH and LH are allowed to increase again, and the endometrium here will become necrotic and slough off, and then you have a period. Okay. So the cycles that are immediately following menarche are anovulatory typically, and this is why you tend to have heavy bleeding and unpredictable bleeding. And this can occur several years post-menarchal. And what what's going on with puberty here is that positive feedback specifically that leads to that LH surge, that takes time to mature. And if you're not having that LH surge and you're not ovulating, then you can get these menstrual irregularities. But interestingly, this whole maturation process is relatively quick. They've done some studies here that have looked that within the first year postmenarchal, about 65% of girls will have 10 or more periods in that normal menstrual cycle interval. And then by 3 years postmenarchal, about 90% of girls will have normal menstrual cycles with that normal cycle interval. Okay. Just to lay a little bit of groundwork on basic definitions and terminology. So the International Federation of Obstetrics and Gynecologists in 2011, they came out with new nomenclature for menstrual aberrations. So, and this was because there was a lot of confusion about previously used terms like menorrhagia, menometrorrhagia. People didn't really understand what that meant. They were using the words interchangeably, so they tried to simplify it. So now the preferred term for any kind of menstrual aberration in volume, regulation, or duration is abnormal uterine bleeding. And so you sometimes will shorten that down into AUB if you ever see that in any of our notes. They did create this lovely little diagram here, and they made an acronym called Palm-Cohen to help kind of further break down the causes of abnormal uterine bleeding. For the purposes of today, you don't really need to focus on that. But what I wanted to point out is that at the top here, abnormal uterine bleeding can be further classified as heavy menstrual bleeding or intermenstrual bleeding. And so that's why we get the term, heavy menstrual bleeding when we're referring to a type of abnormal uterine bleeding. And then as far as causes and things that go for abnormal uterine bleeding in the adolescent population, it's mostly these non-structural causes, and we'll kind of go through those here later on. So heavy menstrual bleeding is a very common problem that adolescents face. They did a population study of 1,000 adolescent patients, and 40% were found to have heavy menstrual bleeding. 20% of those that reported heavy menstrual bleeding had some sort of underlying bleeding disorder. The most common being von Willebrand's disease, and followed by platelet function defects, thrombocytopenia, and clotting factor deficiencies. So what are we expecting for a clinical presentation of someone who has heavy menstrual bleeding? And it can actually be quite various in its presentation. So it can be bleeding that's longer than 7 days, bleeding that's in excess of 80 milliliters. Now, I'm sure none of us are going around and measuring menstrual blood loss, so how would that present in somebody who's coming into the office? So someone who is soaking through 1 or 2 pads or tampons every hour, and this is complete saturation. If they're having to double up protection, so wearing a tampon and a pad, because otherwise they're going to leak onto their clothing. Frequent soiling of bed linens, their clothes, if they're passing larger than 1-inch clots. And then if you're looking at labs, if they have a low ferritin, which could indicate potentially iron deficiency. Also, I just want to point out here on the bottom here that patients' observation of having increased menstrual flow that's impeding their well-being and their quality of life could also constitute as heavy menstrual bleeding. There have been some different studies looking at ways that we as clinicians can better diagnose heavy menstrual bleeding based off of patient symptoms. In the adult world, they actually came up with this, there we go. They came up with this diagram here. This is called the pictorial blood loss assessment chart. And basically what it is it's creating a pictorial representation of how saturated their pads and their tampons are, because you'll have people come in and they're like, oh, I'm changing my pad, every hour. But when you actually ask them how saturated it is, maybe it's just a little bit, maybe it's half. Sometimes it is completely front to back. So this helps to better quantify that. And they've shown that there's an 80% sensitivity and specificity in diagnosing heavy menstrual bleeding if the score is greater than 100. Unfortunately, they have not yet validated this in the adolescent population, but I think it's something that we could definitely potentially utilize in the clinic and explore further, and maybe it would be something that we could use in the adolescent population. Okay, so there are many, many lists of differential diagnosis for abnormal uterine bleeding, and I'm going to highlight a few that I think are most pertinent for the adolescent population specifically. So number one, anovulatory bleeding. So we kind of touched upon this, especially in those first 2 to 3 years. It's very common to have abnormal periods where they're at irregular intervals because that HPO axis, that hypothalamic pituitary ovarian axis, has not yet matured. They haven't developed that consistent positive feedback that's causing the LH surge and leading to ovulation. So it's very common to have these abnormal cycles. Another endocrine diagnosis to consider is polycystic ovarian syndrome, or PCOS. So if you have a patient who is obese, they have evidence of hyperandrogenism. This can be on labs, so with elevated testosterone, for example, or clinically. So they have hirsutism, acne, and they're having irregular periods. This is pointing to PCOS. They also can have some insulin resistance with this as well. So if you notice some like acanthosis nigricans on the back of the neck, these might be some indications that maybe your patient has polycystic ovarian syndrome. Bleeding disorders, also very common. Heavy menstrual bleeding is oftentimes the first presenting sign of a bleeding disorder, and again, the most common being von Willebrand's disease. Pregnancy. They're adolescents, they're going to experiment, it's going to happen. So you have to consider pregnancy. Any kind of bleeding in the first trimester would be considered a threatened abortion, but if they're really having a lot of heavy menstrual bleeding or heavy bleeding in general, you may be thinking that they're actively having a miscarriage. Infection, so if you have a patient, again, who's sexually active, they're not using condoms, considering things like gonorrhea and chlamydia, especially chlamydia, it can cause abnormal bleeding. Medications. If they have, maybe they just had an IUD placed, they were doing really well, and all of a sudden they're having this new onset heavy bleeding, maybe the IUD is trying to expel and it's now in the lower uterine segment. We definitely can see that. They may be initiating a new birth control pill and they're having irregular periods, which is common in the first 3 months after starting a birth control pill. It may be that they're not taking it at their recommended schedule and they're missing days, and so they're having abnormal bleeding because of that. And then anticoagulants is also something to consider. This column right here, uterine, this is mainly any kind of structural anomalies, so like polyps, fibroids. Those are things that you see in like 35-year-old and up women. This isn't something that you typically are going to see in an adolescent patient. So this is a table that was replicated from the the European Journal of Obstetrics and Gynecology. And it's a really nice study. It was an international consensus for the treatment of heavy menstrual bleeding in patients with and without bleeding disorders. I just like this table here because it breaks down the causes of heavy menstrual bleeding by age category, and then just here again bracketed the adolescent patient, the anovulatory bleeding, bleeding disorders, and medications. Those are things that you're kind of thinking about as far as causes most commonly. And then to kind of touch back again on bleeding disorders. So like I said, heavy menstrual bleeding can be the first sign of a bleeding disorder, but there's also some other things that should be kind of triggering a light bulb in your mind that maybe a workup would be indicated. So if they're having, prolonged bleeding after a dental extraction, they're having bleeding complications with surgeries, they're having nosebleeds that are frequent a couple of times a month. They're lasting more than 10 minutes to resolve. They're having to go to the emergency room. There's a family history of bleeding disorders. And then ask mom, too. Like, did she have postpartum hemorrhage or heavy periods herself? These could all be things that could trigger something that would trigger you to do a bleeding disorder workup. Okay, so we're going to first go through some important history that you need to obtain from your patients. So bleeding patterns. So when they're coming here and they're saying, oh, I have heavy periods, you have to figure out how many days are they bleeding, how often are they changing their pad or tampon, and if they're changing frequently, is that because it's completely saturated or is it because of a personal preference? I actually just had a patient yesterday who I said, oh, how frequently are you changing your pads? Oh, like every 2 hours. And I said, oh, is it saturated? Oh, no, there might not be any blood on it at all. I just have to change it. So, I mean, somebody could say, yes, I'm changing 10 pads in a day, but are they actually saturated? Is it affecting their quality of life? So are they missing school? They're not going to their sport activities that they're usually going to. These would be things, important histories to obtain there. Symptoms of anemia, so like lightheadedness, dizziness, palpitations, pica. Reproductive history, so what age did they go through menarche? Are they within that kind of 2 to 3 years that you're expecting abnormal periods? What's their pregnancy history? Are they sexually active? Are they using contraceptives right now? Any concerns for any STI exposures? Associated symptoms would be things like fevers, chills, increasing abdominal girth, bowel or bladder symptoms. And then symptoms associated with systemic causes, again, we're thinking like polycystic ovarian syndrome. Thyroid disorders can cause menstrual aberrations as well. Prolactinemia, hyperprolactinemia, adrenal causes, things like that. Chronic medical illnesses, so liver disease, renal disorder, even cardiovascular disease, those can all affect your menstrual cycle. And then again, medications, and really obtaining a thorough family history. And I want to also point out, you need to ask about thromboembolic disorders. So if you are considering some sort of menstrual management, and we're going to go through those treatment options, if there's family history of any kind of thrombophilia, individuals who've had strokes, clots, heart attacks before the age of 50, you start thinking maybe that there's some sort of undiagnosed inherited thrombophilia, and that can also alter your management. So it's important history to obtain. So for your physical exam, vital signs, I think that's kind of obvious, but it really gives you an overall clinical picture. Is this patient hemodynamically stable? Are they hypotensive? Are they tachycardic? Do they have signs of orthostatic hypotension? Completing a neck exam where you're feeling for the thyroid. Also looking at this back of the neck for acanthosis nigricans. Looking at their skin for pallor, bruising, petechiae, hirsutism, and acne. Hirsutism can be on the face, chin. It can be on the belly. It can be on the back. So inspecting, doing a full inspection, looking at their abdomen, as there signs of hepatomegaly, any tenderness, and then completing a gynecologic exam. It really starts with inspection. So looking at the vulva, looking at the vagina, the urethra, looking at the anus. This is going to tell you where's the bleeding coming from. So, just because they have blood in their underwear doesn't necessarily mean that it's coming from the vagina. There's other, there's the urethra and the anus that could also be the source. Tanner staging is important so you can kind of gauge where they are in puberty and pubertal development. Now, a bimanual exam and a speculum exam, while it can be very useful, it's not, always clinically feasible in a sexually inexperienced adolescent patient. So it's not, you don't have to do it, but you got to look down there. A rectal exam if it's clinically indicated, if you think there's that's the source of bleeding. The kind of take-home point, though, I want you guys to get from all this, number one, are there signs of acute blood loss? Like, does this person need to go to the hospital for inpatient management? Number two, where's the bleeding coming from? All right, so workup of heavy menstrual bleeding is usually done in a tiered approach. So number one, if this patient has evidence of hemodynamic instability, you need to get a type and cross on them because you're potentially going to need to administer blood products. But as far as labs that would be crucial in the beginning to obtain, urine pregnancy test, a CBC with differential, a ferritin, and your coags. So you're looking for abnormalities of pregnancy, you're looking for anemia, thrombocytopenia, possible bleeding disorders, looking for iron deficiency anemia with this initial workup. Some second tier labs to consider, and it kind of depends on your patient's presentation, would be your nucleic acid amplification testing for gonorrhea and chlamydia, TSH if you suspect a thyroid disorder, von Willebrand's disease profile, and then total and free testosterone and DHEAS. Those would be things if you're looking for polycystic ovarian syndrome or some sort of like adrenal abnormality. Third tier approach, this is when you're starting to involve the hematologist to help. You're looking now with platelet function aggregation testing. Is there some sort of platelet defect? As far as an ultrasound goes, it can be helpful if you suspect some sort of structural cause, so like polyps or fibroids. Again, remember, those are not typically what you see in an adolescent patient. But you also can look at the endometrial thickness. So if you've got a thickened endometrium, that kind of, to me, says that she's got more to bleed and more that she could shed from that endometrial lining. If it's thin, maybe she's on the upswing of things, and the bleeding is going to really start to taper off. If you are doing an ultrasound, it does not need to be a transvaginal ultrasound. While yes, that is the best way to image the uterus and the ovaries, again, it's not going to be always possible in an sexually inexperienced patient. So doing transabdominal is completely acceptable. If you're concerned for structural abnormalities and you want a more sensitive test, you can consider an MRI because it is very sensitive at assessing the pelvic organs. So as far as treatment goes, I've kind of broken it down into different categories based off of the severity of the bleeding and the anemia. And we're going to go through each of these categories individually. So we're going to start off with the most severe. So acute heavy menstrual bleeding. This is the patient who presents in the emergency room. I've been bleeding. They're found to have a hemoglobin of 7 or under. So these are the patients that they typically need inpatient admission. You're typing, crossing them, and you're going to be administering blood products. If their hemoglobin's less than 7, there's orthostatic hypotension, you can't get the bleeding under control, and they're still having brisk bleeding, you're going to need blood products. As far as first-line medical treatment, we're looking at estrogen and progesterone hormonal options. And we're going to go through each of these individually in the next slide. But I just want to point out that they've done a lot of studies looking at estrogen and progesterone and stabilizing the endometrium, and it can be as soon as the first 24 hours of initiating the medication. So it's really effective. A small percentage, though, of patients will need some sort of adjunctive therapy. We like to use TXA, which is an antifibrinolytic, which TXA, interesting, the studies have shown to be effective in treating heavy menstrual bleeding alone or in conjunction with hormonal therapy. If medications are just not doing the trick, you can consider doing something called an intrauterine balloon. So it's like, basically it's a Foley catheter, and you can inflate the balloon up to 30 cc's, and it kind of puts pressure onto the walls of the uterus. So it's like you're putting pressure on a wound. And that can be used. It's usually, again, down the line. More invasive measures, though, like things of, a hysterectomy, an ablation, an endometrial ablation, a dilation and curettage, DNC, those are things that we avoid. It can affect fertility, it can cause scarring, and it's only necessary in life-threatening emergencies. Okay, so this is kind of a busy table here, but we're going to break it down. So these are the different types of hormonal options that you can use for a patient who's inpatient, acute, heavy menstrual bleeding, severe anemia. Number one, which we use a lot, is conjugated estrogen or Premarin. It's in the IV route. It's 25 milligrams every 4 to 6 hours. And you need to, at minimum, reevaluate for continuation of this medicine at 48 hours, but usually we're seeing them daily. What's important is you have to maintain this interval of every 4 to 6 hours. So sometimes you'll have your patient that comes in, they're in the emergency room, they give them 1 dose of estrogen, but it takes some time for them to get to the floor. It takes time for people to see them. By then 12 hours have gone by and they've only gotten 1 dose of the estrogen. You're just prolonging their bleeding episode. So you need to have the estrogen going at that 4 to 6 hour interval. If they're not nausea, vomiting, and you want to do oral, you can. So you can do a combined oral contraceptive pill with that contains at least 30 micrograms of ethinyl estradiol, and then a second generation progesterone like norgestrel. And it's basically 1 tablet every 6 hours until the bleeding stops. Both of these regimens here, it can make you really nauseous. So especially if you're doing the oral regimen, make sure that you're adding some sort of antiemetic to that, because if they're just going to throw up the pills, it's not going to be effective either. If there are contraindications to using estrogen-containing hormonal products, so if they have a family history suggestive of inherited thrombophilia, if they have a known thrombophilia, or say they have migraine headaches with aura, that's also a contraindication to estrogen, you could do these progesterone-only options right here. So northinidrone, you can do a 5 to 10 milligram tablet every 4 hours, or you could do medroxyprogesterone, which is Provera, and that's 10 milligrams every 4 hours. And again, you're still reassessing them at regular intervals for need of continuation of this medicine, and you're continuing at that interval until the bleeding stops. Down at the bottom here, these are your antifibrinolytic agents, so your tranexamic acid and aminocaproic acid that can be used alone or in conjunction with the hormonal agents. So continuing on with a patient that has severe bleeding, severe anemia, make sure you're initiating some sort of iron supplementation. This can be oral. If you want to, do IV Venifer and they can continue those infusions as an outpatient, that's fine. But something to help them kind of replete the losses that they've incurred. Once your hemoglobin has normalized and the bleeding has stopped, then you can start thinking about maintenance therapy. So converting, switching them from those like IV estrogen to something else. And you can use a variety of different therapies for this. You could do a combined oral contraceptive pill, and this could be done in a cyclic fashion, meaning you have 21 days of active pills, and then the last week there, that's your placebo week. And so that would be when they would have a regular menstrual bleed. Or you can do it continuously where they actually skip that placebo week and they do 21 days of active pills, throw out the pill back, get another pill pack, 21 days of active pills. So there's no break in the hormones that they receive. You can do the progesterone-only pills like northinidrone, which is also known as Agestin. You could do a Depo-Provera shot, that's once every 3 months. You could do a levonorgestrel implant, that's called the Mirena. You could do tranexamic acid orally. It's 20 to 25 milligrams per kilogram. The one thing, though, I just want to point out, so some of the literature that you'll read will say you can also do a Nexplanon. That's the subdermal implant that goes in the arm. I would caution your use with that just because one of the major side effects with the Nexplanon is that it causes irregular bleeding, and they can actually have pretty significant irregular bleeding with that. So as far as menstrual control, not very good. Contraception, on the other hand, it is actually the most effective form of contraception that we have. So if you're using it for that, that's fine. But in these patients, I would probably shy away from that. If you're going to use a combined oral contraceptive pill, using a monophasic OCP is probably best, and one that has a second generation progesterone. So that would be norgestrel or levonorgestrel. And I say this just because that group of progesterones are actually best for helping with abnormal uterine bleeding. And there's like 90 different pills and brands, so just pick one that you like. I just put up some suggestions on your Crisel, Jolessa. Those probably are common ones I think I see a lot of people on. They're all the same, they're just different brands. Okay, so we're going to move on to a patient who has severe bleeding but only a moderate anemia. So now their hemoglobin's between 8 and 10. So you can still consider inpatient management for these individuals. It just kind of depends on what their ability is to follow up. Do they have reliable transportation? Do they have, reliable care so the family can bring them? If their mom has to work all the time and she can't come, maybe we should just admit her and get her bleeding under control. If you're going to do it as an outpatient, you can do what we call an OCP taper. So there's kind of two different approaches to this. Maybe a more, I would say, aggressive approach would be doing one tablet 3 times a day for 3 days, then one tablet twice daily for 2 days, and then doing one tablet daily for at least 2 weeks after that. And then if the bleeding, though, has kind of slowed by the time you've seen them in the office, maybe their hemoglobin's only 9 or greater, you could maybe do a less aggressive taper in which you do one tablet twice daily for 2 to 4 days. And it's going to be important, again, with follow-up to check their hemoglobin, make sure that their anemia is resolving, and once they are showing signs of clinical improvement, then you can start with a maintenance therapy like we suggested on the last slide. Okay, So patient with moderate bleeding and just a mild anemia, so their hemoglobin is about 10 to 11. This is again going to depend on the presentation that the patient has in the office. So if they're not bleeding anymore and it's just this mild anemia, just start OCPs like you would normal, 1 tablet daily. And I say that 21 days, again, so it's 21 days of active pills. The last week of those last 7 days is a placebo week. If the patient that was bleeding moderately still by the time you're seeing them, but their hemoglobin is, in that 10 to 11 range, you could do an OCP taper. I'd probably only do 1 tablet, 1 tablet twice daily for 2 to 4 days, and then do 1 tablet daily thereafter for at least 21 days, so you finish the pill pack. And then once their hemoglobin has normalized again, you can then initiate that 1 week of placebo, and so they can permit them to have a regular menstrual bleed at that time. And then the most mild form here would be just a mild bleeding with no anemia. I think we see this a lot. We'll have patients come in, my periods are terrible, I'm bleeding all the time, and then their hemoglobin's like 13. So while you don't want to poo-poo their complaints, you can definitely observe them. You can do NSAIDs, you can do iron supplementation to prevent anemia, but you can also just consider starting an OCP for them, be a combined oral contraceptive pill or a progesterone-only pill. There's no magic interval for how long you need to continue OCPs, but a 3 to 6 month trial is completely appropriate, and then you can stop and see how their periods are. Sometimes they just need it to get them through that, that early postmenarchal period, get them over that hump, and then let their body mature, and their cycles will tend to normalize. Okay, so that was a lot of information. So I want to try to bring all of that information and apply it clinically. So we're going to do a case presentation, and I'm going to ask for audience participation, okay? So I'm going to give you the chief complaint stem here. So we have a 13-year-old female. She's in the emergency room. She's complaining of fatigue, lightheadedness. She's got abdominal pain. This has been going on for about 2 days. She actually was in the grocery store with her mom. She had this near syncopal episode, and that's what brought her to the emergency room. And then she says, oh, by the way, I've been having vaginal bleeding for 3 weeks. Okay. So what additional information would you like to know as far as history? How much bleeding? Yep. Mm-hmm. Good. What about medical history? Okay. What else, guys? Family history. And what about family history are we looking at? Bleeding, yeah, signs for bleeding disorders. Anything else? Yeah, medications would be really important. Good, yeah, definitely. All right. So hopefully we hit most of these here. So this individual, she's been bleeding for about 3 weeks. She's using about 4 to 5 pads a day. She's not passing blood clots. She had menarche at 12, so that was about 1 year ago. Bleeding has always been irregular since she started her periods. They can be anywhere from, the cycle interval can be anywhere from 2 weeks to 2 months. She's never been on any kind of hormonal treatment before. She's not on any medication. She has no significant medical history or past surgical history. Family history, just had a grandfather who had some hypertension and diabetes, but doesn't appear that they have any history of inherited thrombophilias or bleeding disorders. Social history, I think, is important. So how is this affecting her life? So she is a runner. She's active in cross country, and she's been unable to go to her practices because she's just so fatigued. So we have a lot of things in the history here that are demonstrating that she has a prolonged bleeding, so greater than a week. So that can be your definition of heavy bleeding. It's also, that's affecting her quality of life. Okay. Okay, what kind of workup do you want to do? So what first should we do as far as just you're here in the clinic, you've got a history, what are we going to do next? Thank you. Vital signs. Okay. We got vital signs, then what? You gonna look at the patient? You gonna examine her? What parts of the physical exam might be most pertinent here? Yeah, so scanning, looking at her skin. Mm-hmm. Doing an abdominal exam, yeah. Yeah, GU exam. Okay. And then, so here are her vitals, so she's a little tachycardic. Oh, one thing I don't think I pointed out before, look, BMI. So BMI is also a very important vital sign to obtain. You know, if you have someone who is obese, they also are more prone to having an ovulatory bleeding. So in this case, her BMI is normal. Physical exam-wise, she's tachycardic, but regular rhythm, there's no murmurs. Lungs are clear, she appears pale. She, as far as her abdominal exam, just kind of diffuse tenderness in the lower quadrants, but there's no rebound or guarding that signs of an acute abdomen. Tanner staging of pubic hair is Tanner stage 4, which is normal. External genitalia looks normal. And you can see that the blood is actually coming from the introitus, the opening of the vagina. And then look at her pad that she's wearing right now, because that also is kind of important. You, again, will have patients that are like, yes, my pad is completely saturated. And then we're like, okay, well, let's look at your pad. When did you put this pad on that last? And then you can kind of assess and say, oh, this pad is 50% saturated. That makes sense, or is congruent with what she's saying or not. Okay, what labs would you like to order? CBC, okay. I'm sorry? Coags. Mm-hmm. Mm-hmm. Good. Okay. So she's not pregnant. Good for her. Coags are completely normal. Her ferritin's low, so she maybe has some iron deficiency anemia. And then look at her hemoglobin and hematocrit down here, so 5.4 and 18.2. Okay, so I want somebody to give me a one-sentence assessment statement. So what is your assessment of this patient in one sentence? You're on rounds right now. Your attending says, what is your assessment? What's your one-liner? Yeah. Exactly. So what's your plan for this patient? What are you going to do? You want to send her home? Does anyone want to send her home? No? Admit? Yeah? Okay. So we can admit her, then what? Yes, thank you. Okay. And some Zofran. You were a good listener. Okay, yes. So we're going to give her some blood with a hemoglobin goal of greater than 7. We're going to initiate our hormonal therapy. In this case, since she had no contraindications to estrogen, we're going to use IV estrogen. We're going to continue that until her bleeding stops. Once her bleeding has improved, we can transition her to an OCP taper. We're going to ensure she has adequate follow-up, make sure she's got a good phone number in the chart, make sure she has a provider that she can see, and we're going to start iron supplementation. Because she's so anemic, I would say 3 times a day is appropriate in this case. Okay, so main points that I want you guys to take home from this presentation today. Number 1, a normal menstrual cycle on an adolescent patient, it's different than an adult. So the interval is 21 to 45 days. They should be bleeding for 7 days or less, and they shouldn't be saturating more than 6 tampons or pads in a day. So if any of that kind of doesn't make sense and you have some sort of abnormal uterine bleeding. Heavy menstrual bleeding in adolescents is very common, and it's often the first sign of underlying bleeding disorder. So there was an article I was actually just reading, and they were looking at, not everybody that has heavy menstrual bleeding has von Willebrand's disease. Von Willebrand's disease, I think, has a incidence of about 17%. But people with von Willebrand's disease, about 74 to 92% will have heavy menstrual bleeding. Okay. The most common cause of heavy menstrual bleeding in adolescents is an anovulatory cycle because of immaturity of your hypothalamic pituitary ovarian axis. Management may require admission to the hospital and administration of hormonal therapy. Most commonly, we'll use IV estrogen, and you're going to continue that until the bleeding stops. And then one little point I don't think I discussed earlier. So when you're doing the estrogen, and if you remember back to the menstrual cycle, estrogen in the follicular phase, it stimulates the endometrium to proliferate, right? So it's going to thicken. So while, yes, it's really good at stabilizing the endometrium and stopping the bleeding, you're also thickening the endometrium. So if you just stop the IV estrogen and you don't transition them to any kind of OCP taper, they're just going to bleed again. So before you stop the IV estrogen, start the birth control pills. Start them on iron supplementation so they can replete the losses that they've incurred, and ensure the patient has appropriate follow-up after discharge so that we can prevent this from happening again. What questions do you guys have? Yes. So if you're going to do, say, for example, if you want to prescribe birth control pills as continuous, you actually have to write on the pack itself, patient taking in a continuous fashion, skipping placebo week. And so usually then they can go to the pharmacy like a week early, and they won't have issues with picking up another pill pack. Or you could do 3 packs at once, especially if they're taking it continuously. That's always helpful if their insurance will allow them to pick up 3 pill packs. And then there are some continuous, just like 21-day pill packs. So I think it used to be called Librel, but that brand was discontinued. But it's levonorgestrel, phenylestradiol. It has a 21-day extended cycle, so it's just 21 days of active pills, and that's it. And so then they can come every 3 weeks to get more packs. Hmm? It's more like their clinical if they're clinically improving, then it's okay to then start to transition them back, onto a maintenance therapy. So I wouldn't necessarily say they have to have a complete return to normal of their hemoglobin. Are they trending in the appropriate direction would be better. And then it's a lot of it's based off of their symptoms as well. Mm-hmm. Not necessarily. We use Zofran. Mm-hmm. Any other questions? All right. Well, thank you guys. If you have anything else, just let us know.